I have one question for our panelists, and each of you can take a crack at this. I believe we're somewhere in the shadow of Rideau Hall, if I'm not mistaken, somewhere close to us, is not. And the next general election is just around the corner. If each of you had an opportunity, what advice would you give our next leader and his or her government with regards to immigration policy, and in particular how it might affect children and youth refugee populations? And maybe, Mally, you might start.
Is this open? Yes. So I won't talk for very long because I have 3 ideas, and those are very simple, and I think we can get them done. We have to scrap the 3rd Safe Country Agreement. We have to prevent all detention of everyone, but mostly children. And we have to keep IFH, make it better, and make everybody register for it, and make that mandatory.
Tell them what 3rd country agreement is.
Of course. So this is something that has to do with the relationship between Canada and the US. So for example, if a refugee claimant moves from or goes from somewhere around the world, goes to the US for a few days or however how long, a few hours, then crosses the border to Canada, Canada says, but you're coming from a safe country. Go back there and do your asylum claim there. And they send them back to the US. But we've proven through these talks, to you watching the news, watching Twitter, that the US is far from being a safe place for refugee claimants and refugees.
So I'll focus a little more on perhaps health systems, as I feel unqualified to speak more broadly. I think the translation piece has been mentioned a number of times today, and I think we've made strides in terms of having translation covered in large institutions, hospitals, and large health centers. I think there's still great barriers to translation being available for health appointments in more private, if I can use that term, physicians' offices or in smaller communities, and across navigating the system, both in schools. I go to multiple school meetings often to advocate for children, and I'm surprised always at how often the teachers and principals say we haven't actually spoken to the family because they don't speak English. Okay. So I think we need funding and an insistence on the wraparound as a very basic minimum that we need to be able to speak to people in their own language or in a language that they're comfortable in. I'll stop there.
I think one of the biggest difficulties is that no data, no problem. And for many of these families, particularly refugee claimant families, it is very hard to find data. The government has data. The government collects data, especially through the census, and I think maybe making it more of a research agenda that we want to collect data so that we can understand what's happening and make better policies that are informed by this data would be critical. But that does mean that we have to share data better with one another. We have to have platforms that can allow us to capture data not just in my little site, but perhaps across Canada, and harness some of the technology that's out there, but have the government as a key player because they also have some of that.
Oh, right, okay.
So, the traditional medical model of care in the past has been very disease-focused, but it's evolving, right, towards more holistic care, prevention strategies, maintenance of physical, emotional well-being, et cetera, and certainly an awareness of the role of social determinants of health and patient advocacy. What are, in your opinion, some of the specific differences, challenges, or priorities that refugee children and youth present in this model of care?
I can start. I think remembering that children they don't live in hospitals, right? Children live in neighborhoods, which means they first of all live in a home, they live in a family dynamic, so understanding and supporting family care is important. Understanding neighborhoods, of which schools matter, recreational programs matter, parks matter. children especially are vulnerable to each part of this life cycle. And so when we're thinking about that, I think that's what makes children so unique. And in many ways, children, a 5-year-old has different needs from a 13-year-old, and recognizing that a child, no matter what stage they're at, still has the right to all aspects of appropriate health in those modalities. But so often we work in our one silo. We're in our healthcare institution. I run a not-for-profit, and so I've learned how to make relationships with other community partners. But that means that instead of just understanding what happens in the clinic with their vaccines, I can call up Julie at the Yonge Street Mission and say, hey, Julie, do you have space in your homework club for one more kid? And she'll say, no problem, Shazeen, we'll get them in on Monday. But I think that's what makes children so unique. And I would argue if we could have that as adults, how healthy could we be too? So maybe we're actually not as special as children, but maybe it's something that all families need to have.
Yeah, I think I would focus perhaps on, again, the health systems. I think one of the risks of a day like today and having amazing colleagues in refugee health is the recognition that perhaps it becomes a niche area or a specialized area, or there's only certain people who own this knowledge or have more comfort. And I worry about that as our population becomes more diverse. I worry about that for our families who settle in smaller communities who don't have as much access to some of those resources. And I worry that those refugee children and families we perpetuate the issue of othering, that they can't walk into their usual neighborhood school, health clinic, nursing clinic, and get the same care at the same quality with the same kindness that their friends can on their soccer team. So I think we need to go away from thinking of this as a specialized niche and thinking of this as a responsibility for all health providers.
I will just add a few things. Yes, absolutely. And the solutions to that are political, because at this table we're clinicians, we're also researchers and teachers, but mostly clinicians, and we deal with patients. And we're interested in them. So we look for the services, we look for ways to improve their lives. But even with the best intentions, and even if we know what those services are, it's not enough. The services are not enough. So we need governments, provincial governments, federal governments, who can step up to the task and ensure that our refugees, but everyone, but our refugees who are in our schools, in our hospitals, in our communities that are now theirs, don't live in poverty, have decent housing and a good living wage in decent working conditions. And this is what is going to make them healthy, which once again is our best measure of success.